Hello and welcome everyone. Today's presentation is on the similar lines of the last video, that is reducing WILI, the use of time controlled adaptive ventilation or APRV in a personalized strategy to protect the lungs. ARDS is a significant clinical challenge primarily managed through supportive mechanical ventilation, which can lead to WILI and increased mortality. Despite protective ventilation strategies which are aimed at reducing WILI, ARDS-related mortality rates have not decreased. And this highlights the limitation of the current one-size-fits-all approach in the diverse patient population. Personalized mechanical ventilation strategies which consider individual patient pathophysiology are urgently needed to improve outcomes. ARDS involves a breach of the blood gas barrier leading to the accumulation of protein-rich fluid in the lungs and inactivation of the pulmonary surfactants, which increases the surface tension and disrupts the alveolar function. The lung in ARDS can be conceptually divided into two compartments: the gravitationally dependent region filled with the fluid and the collapsed airway, which doesn't participate in the gas exchange, and the non-dependent regions, which are relatively normal and ventilated, which is termed as the baby lung. Recent studies using advanced imaging techniques like the high-resolution CT and helium MRI show that ARDS affects the lung more complexly than previously understood, highlighting the issues at the interface of the opening and cyclically closing lung regions. This interface is particularly vulnerable to WILI, exacerbated by overdistension and repeated alveolar collapse and expansion, that is the RACE, factors which influence both time and pressure during ventilation. So let's see what are our current conventional protective ventilation strategies. The ARDS net low tidal volume approach sets a tidal volume of 6 ml per kg of ideal body weight or predicted body weight, which aims to protect the normal lung tissue from overdistension while allowing the collapsed lung tissue to rest. Low tidal volume ventilation includes maintaining the plateau pressure below 30 and using a PEEP to prevent loss of end expiratory lung volume and minimize the atelect trauma. Despite being a standard care, ARDS-related mortalities have not improved significantly with these type of approaches. Recent findings suggest that in patients with low respiratory system compliance, high tidal volume increases mortality, whereas in those who have a higher compliance, a slightly increased tidal volume may actually reduce the mortality. Driving pressure and mechanical power are emerging as more reliable indicators for WILI than the size of tidal volume per se, and leading to adjustment in the tidal volume and air pressure is done to optimize these factors, that is the driving pressure and the mechanical power. Persistent use of low tidal volume leads to issues like progressive de-recruitment of the lung regions, necessitating interventions like high-frequency ventilation and extracorporeal oxygenation. The strategy of resting collapsed lung areas, while intended to be protective, can lead to multiple pathological conditions like fibrosing alveolitis, increasing pulmonary vascular resistance, and potential right ventricular failure. Long-term atelectasis leads to multiple physiological problems including hypoxemia, hypercapnia, oxygen toxicity, and potential of permanent lung damage due to fibrosis. Atelectasis reduces the effectiveness of the surfactants necessary for a lung expansion, which exacerbates the VF ventilation perfusion mismatch, leading to further complications such as patient ventilator asynchrony and increased risk of pneumonia. So this is what our current approach is. We have the same tidal volume which needs to be given to all the patient, whether mild, moderate or severe. But what the problem happens is, once the patient goes into a downward spiral, it is a never-ending story and it usually results in requirement of an ECMO and ultimately death. However, with personalized approach, we can plan to stabilize the lung at a moderate setup and then see gradual improvement. So what is this open lung approach? The open lung approach aims to prevent progressive shrinking of the baby lung, a phenomenon described as the WILI vortex, by applying sufficient PEEP and using recruitment maneuvers to maintain an end expiratory lung volume. Despite the physiological rationale behind OLA, it has not demonstrated a reduction in the mortality. For instance, the alveolar recruitment for ARDS OLA increased mortality compared to the standard care, that is 55 versus 49. High frequency oxygenation, another form of OLA capable of achieving higher mean airway pressures, was similarly failed to improve outcome, possibly due to the heterogeneous airflow distribution causing variable parenchymal strain. Surprisingly, clinical trials using OLA have shown no significant long-term benefits in terms of lung recruitment. Data indicate that minimal differences in the compliance of the respiratory system and only mild improvements in the oxygenation between OLA and the control groups. The implementation of the OLA often necessitates deep sedation and the use of neuromuscular blocking, which may show inconsistent benefit and even have worsening the outcomes. The failure of OLA in trials has prompted some experts to suggest abandoning this approach altogether, although the scientific rationale still supports the potential of success if applied more effectively. Current OLA strategies that attempt to rapidly reopen the lung using high airway pressures may not be suitable, as they fail to account for the lung's time-dependent nature and the complex interplay of surfactant dysfunction, which means that even if I do get a recruitment right now, I'm not very sure whether that recruitment is going to remain after 1 hour. So there is a time-dependent nature of the lung's ventilation. A more gradual recruitment strategy, acknowledging the lung's time dependency, may offer a better approach, particularly considering the varying severity of the lung injury. Recent studies suggest that ARDA phenotypes reflecting different underlying pathogenesis may influence outcomes more significantly than previously thought. This would mean that understanding patient-specific phenotypes could be crucial in effectively applying OLA and reducing the VILI. So what we have is a personalized approach to the mechanical ventilation. The personalized approach to mechanical ventilation aims to address the shortcoming of the low tidal volume and the OLA by reversing progressively alveolar instability and halting the race, that is repetitive alveolar collapse and expansions, thus preventing what is called as the VILI vortex, which we have previously discussed. This strategy involves deliberately opening the collapsed lung tissue and maintaining it in an open state throughout the ICU stay, thereby minimizing atelic trauma as well as volume trauma. Achieving this involves a controlled, gradual reopening of the lung over extended periods using incremental opening pressures to minimize the tissue damage. This contrasts with the current recruitment maneuvers that apply very high pressures rapidly, which can exacerbate the tissue injury. A study by Deonte et al. Supports this approach, showing decreased ARDS mortality with high levels of PEEP and occasional recruitment maneuvers. A key aspect of this personalized approach is to avoid the rapid race during expiration, which propagates atelic trauma and predisposes the lung to volume trauma by over-distending adjacent open alveoli. Now, the approach recommends maintaining airway pressures above the highest closing pressure at all times to prevent alveolar collapse, a challenge given the elevated and variable closing capacities in the ARDS. The timing of the airway and alveolar pressure changes is crucial, as the fluid dynamics and mechanical properties of the lung tissue introduce a delay in the pressure transmission and alveolar closure. The strategy suggests optimizing the duration of the expiration to be less than the time it takes for the alveoli to close, while also allowing sufficient time for the gas exchange, addressing the lung's increased time requirements for opening and the quicker tendency to close as the lung injury worsens. Ultimately, this approach seeks to find a balance between sufficient ventilation for adequate gas exchange and the mechanical requirement to keep the lung open and stable, tailored to specific pathophysiological condition of each ARDS patient. So, this is the current approach that we are doing. That is, we have a set PEEP and a mean pressure, and there is inspiration and expiration. What happens with APRV is that what we are using is a time controlled method. Here you have a very small expiration. There is a continuous inspiratory phase where you have a CPAP, and you have a very small expiratory phase. The expiratory phase over here is quite long, which has been dramatically decreased over here. So in that, as you can see in the flow curve, you will find what is called as the slope of the expiratory flow. This is going to help us in a later interpretations. So here we have two phases, the expiratory de-recruitment phase and the inspiratory recruitment phase. Here, we keep a prolonged period of CPAP, which allows the lung to slowly expand. And during the expiration, as we are keeping it very, very small, this expanded lung is not allowed to release completely. Before the flow is complete, we are changing into a inspiratory phase, thereby preventing the collapse of the lungs. So how do we tailor this? So there are three basic steps. The first is, this is the normal, where you see the slope is like this. As in the moderate ARDS, as the airways collapse more quicker, the flow reaches the point faster and your slope is increased, and you have a more steeper slope in severe ARDS. So what is our target is to keep this at 75% of the peak expiratory flow rate and to adjust our expiratory time accordingly, so that we do not allow these lung areas to collapse. So as the lung worsens, my expiratory time must gradually come down. If I don't do that, my lung is going to collapse. If I keep this 0.5 seconds for a severe ARDS, then more of my lungs are going to collapse, as my lungs is now much more steeper. So what is stabilization and gradual recruitment approach? So this time controlled adaptive ventilation adjusts the APRV mode to address the limitations of the OLA by avoiding rapid closures with each expiration and gradual opening of the collapsed lung tissues. Now, this approach has a time controlled PEEP to maintain the alveolar opening by setting a short period of expiration that doesn't allow the alveoli to de-recruit. Now, what does this involve? It involves applying a upper pressure, that is P high, which is standard for APRV setting, with a prolonged T high time, which allows the lung to stay open for a long period of time, and a very small lower pressure phase, which is called the release phase, and where we actually let the expiration to take place. The combination of these two phases facilitate efficient CO2 removal through both diffusive and convective gas exchange. What are the key elements of this? The release phase is crucial to control the passive exhalation flow, effectively regulating the retained lung volume, that is EELV, and thus indirectly producing a time-controlled positive end expiratory pressure, even if the P low is set to 0 centimeters of water. Now, this phase is critical to maintain the lung volume by using time, not just pressure, to control the dynamics. We are reducing our expiratory time so much by checking the flow of the expiratory flow. We are stopping the PEEP to get lost. And the lung's viscoelastic properties, modeled as a spring and dashboard system, suggest that the time is a fundamental controller of lung inflammation dynamics. Thus, timing of the T low is tuned to just brief enough to prevent closure, but long enough to allow efficient gas exchange. What is the clinical implication? A P high is set based on the lung's volume requirement, the intravascular volume status, ensuring that the pressures are personalized and adapted as clinical course evolves. However, my time controlled emphasizes on adjusting the T low to keep my expiratory flow characteristics constant. This is determined by the slope, as we have already discussed. Now, what are the challenges and controversies? Despite its potential, a viewpoint paper suggests that APRV, typically associated with this time control approach, should not be routinely used outside of clinical trial due to lack of any conclusive evidence. Now, however, the criticism of APRV often stems from myths and misconceptions, and the lack of definitive harm demonstrated in trials calls for more nuanced understanding and application of the method in ARDS management. Advocates of the time control approach argue that it represents the most scientifically grounded, potentially beneficial approach, particularly when personalized and meticulously managed to prevent willy. So what is our take-home message? The take-home message is we still have very high mortality despite different ventilation plans in ARDS. The traditional method, that is low tidal volume, high flow oxygen, high frequency oxygen, open lung approach, have not reduced the VLE. Volume-to-mat interface between the collapsed and the open lung tissue is occurring. This race is still occurring, and the need for personalization is the need of the hour. So how do we do this? To do that, we need a time controlled approach. which is slowly and progressively reopens the lung. Using patient-specific expiratory duration, we implement a closed-loop system, and utilizing the slope, we adjust the expiratory time. Evidence of efficacy is still not shown, though it is being effective in some animal models. So this diagram basically summarizes what we have discussed till now. In the conventional approach, we have a fixed tidal volume of the patient, and we have some targets. And this ventilatory strategy is not adjusted as per the compliance of the patient, which results in very unsafe delta p values and high peeps, which are not changed as the patient condition evolves over the course of the ICU. If it worsens, these values become very unsafe, and we go into a downward Willi vortex. However, in this particular approach, that is time approach, what you see is, as the compliance is low, we start with very low expiratory times, and gradually we increase it, even increasing the tidal volumes as our lungs slowly starts to improve. So this is the basic approach. However, this is not something we will recommend to do in all patients. This is mostly should have been and should be done in a clinical trial setup. A very severe ARDS is there, which is not improving despite your proning and other interventions, and you don't have facilities for an ECMO, then probably you can try these approaches. Thank you for your patience.